going to talk about a patient with an alcohol use disorder. And this patient, her name is Barbara, not her real name. She's a 34-year-old female who presented to me for management of her ex's alcohol intake. She was drinking about a bottle or more per day. She says that she was doing well until about 6 months prior to her visit with me. At that time, she was drinking about 1 to 2 glasses of wine, and she felt that that was her baseline, and she was okay with that. But she had a few stressors, and so that caused her to increase her alcohol intake. She said her alcohol use was interfering with her married life, and she wasn't able to focus on her graduate school. She was taking naltrexone to help control the drinking. It's called the Sinclair protocol, where you take it about an hour before you go drinking. It's supposed to block the endorphins and the pleasure you get from drinking. So it's supposed to help you be able to control what you take in. And then she was taking melatonin, which wasn't helping her. And she had a history of pretty significant emotional abuse in her during her childhood, and she was seeing a therapist for that. So again, I also do the biopsychosocial spiritual model of recovery, but I focus on the biology because the idea is that if you can change the biology, if you can make the patient feel better by nutrients, medications, a good diet, and then testing and lifestyle interventions, if you can address the biologic imbalances, then they would be able to pay attention to the psychosocial spiritual aspects. So for me, in my practice, biology is key, and that's where I put my focus. So usually before they come to see me, I send them a bunch of questionnaires, and that's always a little flexible, how many and what I send them. But in general, it's a Pyloria assessment questionnaire, neurotransmitter depletion, a 1 to 3 day diet diary. Everyone gets an adverse childhood experience questionnaire, and then a comprehensive medical history. So these are the 3 questionnaires that I do consistently, and I will talk about each of these in detail. With the Pyloria questionnaire, we're looking for long-standing anxiety issues that are due to B6 and zinc deficiencies that we can correct right away while waiting for the actual test results. And with the neurotransmitter worksheet, we're looking for about 5 different depletions that we can also correct immediately with amino acids. And for many patients, this may make them feel better almost right away. And changing a patient's food intake when and where, when and what is fundamental. So this is the Pyloria symptom questionnaire. We saw this a little bit this morning. So Pyloria is a genetic epigenetic condition that responds well to zinc, B6, and a few other nutrients. You can also find increased purines in individuals with stress or microbiome imbalances. Again, you would find Pyloria in someone with lifelong anxiety. It's thought to be present in 40 to 80% of alcoholics. As I mentioned earlier today, it's not recognized as an ICD-10 diagnosis. Pyloria or purines are natural degradation products of the heme molecule, hemoglobin. So these purines, they bind to zinc and B6, and they excrete it into the urine and out the body. So the body essentially is deficient in zinc and B6. And these 2 nutrients are very important for neurotransmitter synthesis. So the way we diagnose it is with a questionnaire and a urine purines test. There are many different questionnaires by different folks, but essentially you're looking for neurobehavioral symptoms. So the questionnaire up there is by Trudy Scott, and Dr. Walsh, Dr. Greenblatt, Dr. Mensa, Trudy Scott, Klinghardt, Dr. Nathan, and Christina Veselak. There are many people who talk about Pyloria. So if you wanted more information, you can refer to those resources. And the book that I've mentioned there is also pretty good. And the article there is one of the first articles that really talk about Pyloria and some of the consequences of it. So once you can make the diagnosis, or once you have a suspicion of Pyloria, what you can do is give them some nutrients to make them feel better. So this is another questionnaire by Julia Ross. You can find it on her website. And these are the nutrients that you would give: high B6, high zinc, then omega-6s, lots of antioxidants, and some baseline nutrients. So now we're going to talk about the neurotransmitter depletions and how we can improve the way a patient feels pretty quickly with a few nutrient precursors. Dr. Zawicki talked about the reward pathway, and the reward pathway was described by Dr. Bloom. He's one of the pioneers in looking at precursor treatment for addictions. The cascade that he described involves serotonin, enkephalins, the GABA neurotransmitter, and ultimately dopamine. And it also involves different areas of the brain: the hypothalamus, the substantia nigra, VTA, and nucleus accumbens. Addiction is basically a disruption of this reward pathway. And this could be either due to depletion of neurotransmitters because of diet, environment, could also be genetic because you're not able to make the receptors that you need. So there are many things that can cause an imbalance in the reward pathway. This is a really awesome and useful chart that was created by Julia Ross. It has been used to heal thousands of patients with addictions and mental health issues. It's about 80% effective. So what we're trying to do is we're trying to assess for neurotransmitter deficiencies. These particular ones are serotonin, endorphins, GABA, and catecholamines. And she has a couple of questions around low blood sugar. So what you do is you have the patients rate their symptoms from 0 to 10. And column A lists all the neurotransmitter deficiency symptoms. So type 1 is low serotonin. And those are the symptoms that may indicate a patient has low serotonin. And type 2 is low blood sugar. Type 3 is low endorphins. Type 4, low GABA and catecholamines. So once the patient rates these symptoms from 0 to 10, you can then ask them what are the substances that they're using to make them feel better with the symptoms they're experiencing. It could be medications, it could be diet, it could be chocolate, sweets, whatever it is, they'll mark it down. Then column C are the amino acids that you can give them. These are the precursors to the neurotransmitters. And column D is how they would feel once they are repleted with the neurotransmitters. So the way you would work with this chart is you would gather this information either when the patient comes in or before they come to you, they will send it to you. Then you would ask them which of the categories they would want to address. So, for example, this patient, I hope you can see these ratings. This patient gave a score of 10s for many of the low serotonin symptoms. And she also gave a bunch of 10s for low catecholamines and for low GABA. So then you ask the patient, which is your most troubling area? And they will say that to you. They'll say, okay, it's serotonin. I'm just not feeling great in the afternoon, or I'm having these obsessive thoughts, or I'm having winter blues or irritability. Then what you would do is you would give these precursor amino acids. So for low serotonin, you can give tryptophan or 5-HTP. And you can do this in your office, or if you're doing telehealth, you can do it by video. You give them the amino acids, so you've already sent it to them, so they have it on hand during your visit, or if they're coming to the office, you have it at your office. And then you give it to them, you have them swallow it, you time it, and you say, okay, it's 10 minutes later, you ask them how they're feeling. And then if they're not feeling that much better, you can try to increase the dose. So that would be, you give them another capsule. And then you can keep going up, maybe 2 or 3 capsules for that particular depletion, neurotransmitter depletion. But you have to make sure that they also have these cofactors in place. Like for tryptophan, you need iron and B6. So they need to have that on board, or you can give that to them in addition. And then for low catecholamines, you would give tyrosine. And this, again, you can do at the office. So that's called trialing. So you're trialing to see if the patients respond to the amino acids that you're giving them. It's pretty neat because oftentimes the patients will feel better pretty quickly. If you've gotten the right, if they've answered correctly and you have the right amino acid, they do feel better and they'll give you that answer. And it's good for alcohol use disorders. Opiates are really also good. So it's called trialing when we do this in the office and you're trialing to see which amino acid would be good for the patient. So I think you need to have more training. So you can go to either aminoacidtherapy.com or Julia Ross, or Trudy Scott also has it. And Julia Ross has a couple of books, the Diet Cure and the Mood Cure, where she really explains how to do some of the trialing. But it's best to do training. And I took the training with Christina Veselak, and that's the aminoacidtherapy.com. And here are the cofactors that you would think you should give the patients. All patients should get cofactors. And then there are some precautions with it. But again, if you have a very sensitive patient, you may not want to do this with very high doses. You might have to start very small. And as I mentioned earlier this morning, I don't do this with patients with benzo use disorders. I mean, benzo dependence, because they're just very, very sensitive. And what's the data behind all of this? So in this article, they say that the levels and possible functioning of several neurotransmitters can be influenced by the supply of their dietary precursors. So you can give the precursors for serotonin, dopamine, and noradrenaline, and that would increase the neurotransmitters. So that's one paper. And here's another paper that says that diet influences the brain pool of amino acids, particularly tryptophan and tyrosine, and then availability of these two would convert to the neurotransmitters that are needed. And in this study, what they did was actually give patients amino acids, so D-L-phenylalanine, glutamine, tryptophan, and vitamin B6. They gave patients, alcoholic patients, this combination. And what they found was that this led to the restoration of neurotransmitters and reduced the desire to drink, and the patients had less withdrawal symptoms. So this was compared to a placebo. So this was a randomized controlled study in an inpatient setting. A similar study was done in an outpatient. Actually, this is also inpatient. So this was done in a treatment facility for cocaine users. And there they improved the AMA rate leaving the facility against medical advice from 62% to 95%. So prior to this combination amino acid, 35% of patients left AMA. And after they instituted this combination treatment, amino acids, less than 5% left against medical advice. And here, there are plenty of articles. Here's another study that says that nutrient imbalance is a reasonably strong and consistent correlate of both drug and problem use and problem alcohol use. So dietary micronutrient consumption and vitamin intake appears to be protective for substance abuse. Another one, malnutrition is prevalent among individuals with alcohol and drug use disorders because they don't have the substrates to make neurotransmitters. And not having these precursors promotes drug-seeking behaviors and impedes recovery. In this study, they actually checked the vitamin E, C, and A levels, compared addicts to non-addicts, and they found that these levels were significantly lowered among addicts compared to non-addict controls. So what we're saying is that we can improve someone's serotonin levels with giving them L-tryptophan or 5-HTP, and improving dopamine with L-tyrosine or L-phenylalanine. Same thing with GABA, giving them GABA. Taurine and glycine also. It doesn't work directly on the GABA receptor, but it also helps with the whole GABA pathway. And then endorphins. Endorphins, actually, they're multiple amino acids that go into making an endorphin, as Dr. Zawicki was saying, but you can increase endorphins by giving D-phenylalanine, which prevents the breakdown of endorphins, thereby increasing the amount that's available. So the third area that I'd like to discuss is hypoglycemia. I mentioned this morning, and this is really important. So we talked about Pyloria, we talked about neurotransmitter depletion and repletion. Here, hypoglycemia is defined as low blood sugar. So it's the leading trigger in addictions, and therefore correcting low blood sugar is very important. With the right kind of testing, close to 90% of patients with all addictions have low blood sugar. Glucose dysregulation is a pandemic in the society. As an example, an addicted person may be working hard in a recovery program and has learned new and helpful skills to counter the urges to relapse. However, in a hypoglycemic moment, his access to those skills that he learned is physiologically blocked, and the conditioned response of reaching for the drug of choice is activated, leading to relapse. So what are the hypoglycemia symptoms? So these are it. So fatigue, depression, headaches, mood swings, anxiety, dizziness, similar to withdrawal symptoms, right? Like when patients describe their withdrawal symptoms, it's very similar to these. So how do you define hypoglycemia? It's probably somewhere around 70, 60, 50, somewhere around there. And also a significant blood sugar drop of 10 to 20% can also cause hypoglycemia symptoms in some patients. And as I said before, low blood sugar has been consistently shown to be a powerful trigger for use and relapse. This slide shows the results of an oral glucose tolerance test that was done in an inpatient facility in Colorado. So Christina Veselak just pulled 20 charts randomly and looked at their results. And what she found was that virtually everyone, didn't matter what kind of addictions they had, on a 5-hour glucose tolerance test, almost all of them were hypoglycemic. And Joan Matthews Larson, she had an outpatient alcohol treatment program, and she was also doing oral glucose tolerance tests. And what she found was that many of the individuals, at the lowest point of their blood sugar, they had grogginess, sleepiness, trance-like states, depression, fatigue, mental confusion, and lack of concentration. So not many people do 5 or 6 hour oral glucose tolerance tests anymore. So this paper is from 1966. And I wanted to show you the different patterns of hypoglycemia and why you really need to do a prolonged test like this to diagnose hypoglycemia. So in chart 1, which is top left, the patient's baseline sugar was 82. When they drank a glucose bolus of about 75 grams, the sugar went up to 168, it stayed high, and then it didn't hit nadir. The sugar didn't go down to the bottom until 4 hours. In chart 2, the patient had a starting glucose of 108. In 1 hour, it went to 131. Then within an hour, it went from 131 to 81. So that's a significant drop. And then it stayed around the same. And in the third chart, the sugar started at 77. It went all the way up to 166 in an hour. It stayed up, and it didn't hit nadir until 5 hours. So Dr. Salzer, he did oral glucose tolerance tests on 300 patients who had come to him for various neuropsychiatric symptoms. So unless you do these tests, many patients are given diagnoses of different kinds of neuropsychiatric problems. What he found in his 300 case series is that patients are coming in with depression, insomnia, anxiety, irritability, exhaustion or fatigue, headache, dizziness. So you can see that if you don't have this, someone may be diagnosed as having depression, and then they're given a medication for depression. So just to keep in mind that hypoglycemia is very prevalent in society and 100% prevalent among patients with addictions. So what Dr. Salsa did was he gave patients a high protein diet, low carbohydrates, and free of any caffeine. And he saw that 85% of patients recovered. Obviously, we're not doing 5 and 6 hour oral glucose tolerance tests, but we can collect data on the patient's nutrient intake through a food diary, either a 1-day, 3-day food diary. And for the patients with addictions, you can sort of say that they're all hypoglycemic and they probably all have poor intake. So when you're treating someone with addictions, you really need to pay attention to what they're eating and how much they're eating and when they're eating, because that's going to be one of the keys to recovery. And the reason we need to control hypoglycemia is because you need a certain amount of sugar in the brain, in the prefrontal cortex, to make good decisions. This paper suggests that the availability of blood glucose is one important part of self-control. When glucose is low, the self-control failures are likely because self-control and willpower requires a certain amount of energy that comes from glucose. So what do? So you recommend a pro-recovery diet, high protein, high fat meal every 4 hours. Breakfast is a must. They just have to eat breakfast, and then high protein snacks in between. And so when a patient comes in to see you, you reinforce this diet. And then if there's a relapse or a slip, you actually ask them, how long has it been since you last ate? What was the content of your meal? And then you can use supplements like chromium, biotin. Glutamine is very, very helpful to balance out the sugars. And of course, the adrenals are very important. That's why they call glucocorticoids, because the adrenals are important for balancing blood sugar. And this is a sample of a pro-recovery diet. This was developed by Patty Rees. She's part of Christina Veselak's program and also for the Alliance for Addiction Solutions. Basically, it's what I just said: high fat, high protein, eating often, and eating breakfast. So when the patient came in, so this is the first visit, I review the questionnaires. Sorry, getting back to the patient. So I'm reviewing the questionnaires, I review the medical history, and then I talk to the patient about their goals. So for her, her goal was to reduce the amount of alcohol she consumes, and she wanted to improve her sleep. So what I did was, with the neurotransmitter depletion chart, I worked it out with her. I did a couple of trialings, and I gave her the nutrients, the amino acids that came out of that trialing. Then I continued the naltrexone, which is a Sinclair protocol, recommended a good diet. Movement is also very, very important. Psychosocial supports, which she had. She had a wife, she had community in the college, and then I do comprehensive testing. These are the different use disorders and the NIDA recommended treatments. So for alcohol, you can see that they disulfiram, acamprosate, and naltrexone are approved for treatment. And then you have all of these behavioral therapies that they can access to for alcohol use disorder and treatment. So these are testings I do. I do this routinely on all the patients. And sometimes actually patients refuse to do them, but I recommend it. So do a comprehensive nutrient panel, just look at all the different nutrients, oxidative stress, and mitochondria, amino acids, fatty acids. Then I do a hair tissue mineral analysis. I find it really useful for heavy metals and minerals. Then, of course, I do a stool testing for gut health, microbiota evaluation, and digestion. I do urine and saliva testing for hormones. And occasionally I'll do food sensitivity testing. So these are this patient's results. Her vitamin D level, as you can see, was extremely low. It was 10.7. Her ALT and AST were high, indicating vitamin B6 deficiency. Interestingly, you can see that her A1C was 4.8. That indicates that her sugar is probably low during the day. And her insulin levels, this was a fasting sample early in the morning, her insulin level was 2, and her glucose level was 79. Also, some indication that she may have hypoglycemic periods throughout the day. And here's the nutrient panel test result, and shows that she needs a lot of Bs. So this is B6 and B complex. So here is indications that she needs B12, and her homocysteine was high, indicating that she needs B6, B12, and probably not her, she maybe doesn't need B9, probably B6 and B12. And this was her urine hormone test. You can see here that she had a very dysfunctional HPA axis. The normal HPA axis should be going up, coming down, and this way. So hers completely dysfunctional. She had an overall low cortisol. And then you can see that she had low cortisol. And at night, it went up. So this might be the reason that she's having so many sleep difficulties. As I said, I do the gut microbiome test. And hers was essentially, she had H. pylori. The first page was good. So she had H. pylori, and here you can see a lot of virulence factors, and the H. pylori amount itself was good, was a little high. And then here it shows that she has some level of dysbiosis. She had a lot of different dysbiotic bacteria. And here she had 2 parasites. She had Endolymax nana, and then she had Trichuris, which is whipworm. Then you can see that her digestive marker was pretty low. It was 364. Usually we like to see it around 500. The secretory IgA was also low, indicating that her gut may not be able to fight off the infections, maybe indicating that's why she has dysbiosis and these parasites. And her zonulin was a little bit high at 193. Fecal zonulin is not the best test for leaky gut, but it's an indication. And she's drinking alcohol, so highly indicative that she probably had issues with her gut, probably a leaky gut. And so I gave her a lot of supplements, and she was willing to take it. So when you do a lot of testing, you're not going to be able to give them all of the support they need, all the nutrient and hormonal support they need. You sort of have to figure out what's most important, and that's what you address. And you ask the patient, what's most important to you? And this is what I came up with: amino acids, vitamin A, vitamin D, carnitine, then B6, lots of B6, C, B12. She needed digestive enzymes and hydrochloric acid. I usually actually give a lot of magnesium to patients, and then omega-3s and multivitamin. A few weeks later, this is what she said: I have stopped using alcohol since the beginning of May. There were 2 nights, one with friends and one at a wedding, where I did have naltrexone and wine. But besides this, I've not been using. I haven't experienced any cravings, and in fact, drinking wine made my sleep so poor that it was kind of off-putting. So that's pretty good. You know, she had a good response, and she stopped drinking for a few weeks. But what the data shows is that if someone is abstinent only for 1 year, they have a 64% chance of relapse. So pretty high risk of relapse with only 1 year abstinent. But if you can make it to 3 to 5 years, then your risk of relapsing to your drug of choice is much less. Here it was 14%. So that's what you're doing. Every day is a success, and you really need to get them to 3 to 5 years of abstinence. And I think if you concentrate, for me at least, if I can concentrate on the biology, help them get better in terms of having that kind of support with the physiological aspects, then they can concentrate, they can put more attention to the psychological, and then the social, and then the spiritual, the purpose. All of those are very important, but I think a lot of us in addictions, well, those of us who are looking at addictions from this whole nutrient perspective, we think that fixing the biology or addressing the biology is really very important early on. And here, to really get them to 5 years, there are many different things that you need to address, and they can all be in stages. Nothing has to be done immediately except the biology. So this chart was created by Mark Stiles, who works with Christina Veselak in our group. And so he created this chart. You can look at it. It's very hard to read, but maybe it's more legible in your handouts. But anyway, so that's, there are a lot of different issues you would need to address to get someone to the 5-year mark. And this is a really good book by Joan Matthews Larson for anyone interested in getting to sobriety with alcohol use disorders. She's really good. There's a good reference book. So thank you. There's about 10 minutes for questions. And this is